For the correction of any malocclusion, we require space in order to move the teeth into ideal locations. And there are various methods for this. The appropriate method of gaining space in a given malocclusion should be decided after proper diagnosis and a proper treatment planning. The planning space is an important aspect of treatment planning. The space is required for the correction of crowding, retraction of procline teeth, leveling of steep curve of spee, derotation of anterior teeth, correction of unstable molar relation. There are different methods of gaining space. The first one is the proximal stripping. Then second comes the expansion, extraction, molar dislocation, uprighting of molars, derotation of the posterior teeth, proclination of anterior teeth. Proximal stripping is a method by which the proximal surfaces of the teeth are sliced in order to reduce the mesiodistal width of a teeth. Other names are reapproximation, slenderization, disking, and proximal slicing, usually done in the lower anterior segment but can be done on upper anteriors and buccal segments of upper and lower arches. The indications of proximal stripping are Bolton's excess, aid in retention, maintain the profile, maintain class 1 and molar relation, caries analysis of 0 to 2.5 millimeters. Contraindications young patients. Why? Because of high pulp chamber. High caries index, poor oral hygiene and enamel hypoplasia. Advantages are borderline or to non-extraction cases. A favorable overjet and overbite can be established and more stable results because of contact area is broadened. Disadvantages are roughened proximal surface, more chance for plaque retention, increased caries susceptibility, then sensitivity, alteration of the tooth morphology and loss of contact, and there are high chances of foot impaction. The diagnostic aids for proximal stripping includes the arch perimeter analysis. Arch perimeter or caries analysis showing a tooth material excess of 0 to 2.5 millimeter over arch length. Bolton's analysis. Bolton's analysis revealing an excess of tooth material in either of the arches is an indication to reduce the tooth material in that arch. IOPS. This would give an idea of the enamel thickness and a rough estimate of the amount of enamel that can be removed from the proximal surface without exposure of pulp chamber. The amount of proximal stripping, not more than 50% of the enamel thickness. Never remove more 0.3 millimeters from a single tooth surface. According to Sheridan, 0.4 millimeter reduction per surface of the posterior teeth and 0.25 millimeter in the anterior teeth, thereby gaining a total space of 8.9 millimeters. We can use a metallic abrasive strips or safe-sided carborundum disc or long thin tapered fissure burrs for this purpose. Then fluoride application, increased caries susceptibility after proximal stripping is managed by a comprehensive fluoride program following procedure. Expansion. One of the non-invasive method of gaining space, usually undertaken in patients having constricted maxillary arch or in patients with unilateral or bilateral crossbite. The expansion can be skeletal or dentoalveolar. It can be removable or fixed. Removable, we have got in the dentalveolar removable, we have got coffin springs and slow expansion screws. And the fixed type, we have got rapid maxillary expansion, quad helix, and W arch and arch wires. Jazz screws are used in removal for slow expansion. Extraction. One of the frequently used method for gaining space for orthodontic purpose is by extraction of one or more teeth. Extraction that is undertaken as a part of orthodontic treatment is called a therapeutic extraction. Premolars are the most frequently extracted teeth as a part of orthodontic treatment. Extraction of one premolar from each quadrant provides enough space to correct the problem of crowding or proclination without unduly hampering functions and aesthetics. It is not uncommon to extract molars or the lower incisor during orthodontic therapy, but extraction of the canines and upper incisors are usually avoided. Answer to which teeth to extract for a particular patient should be based on a sound diagnosis. Distalization. It's aimed at moving the molars in a distal direction so as to gain the space. Distalization of the maxillary molars assumes significant value in the treatment of mild to moderate class 2 molar relation associated with a normal mandible. Thus, in these cases, distalizing the molars can be done avoiding extraction. Ideal time for distalization is during the mixed dentition period before the eruption of the second permanent molars. Distalization methods is brought about by the two methods. One is the extraoral method and intraoral method. Extraoral methods by the use of headgears. The disadvantage of headgears is patient cooperation is essential for timely wear of the appliance, and appliance if not worn continuously, so intermittent in action resulting in prolonged treatment time. Intraoral methods, there are a lot of intraoral methods. To overcome the drawbacks of extraoral appliances, various intraoral appliances were introduced. Sagittal appliance, this appliance consists of a split acrylic plate joined together by a jack screw. The acrylic plate is sectioned in such a way that the tooth to be disliced is isolated, while the rest of the arch is used for the purpose of anchorage. Jack screws are positioned that their long axes are parallel to the occlusal plane as well as to the buccal surface of the molars. Discalization using intraoral magnets. That is using intraoral repelling magnets to dislice the molars. The magnets are placed on the molars to be disliced and anterior to it. The anterior anchorage is reinforced by a dance holding arch. Next is a pendulum appliance. It is an intraoral dislication appliance that incorporates a modified dance button for the purpose of anchorage. It consists of a stainless steel wire with a helix, the distal end of which is inserted into the sleeve of the palatal aspect of the molars to be disliced. Dislication is brought about by opening the helix and forcefully engaging the distal end into the sleeves. Discalization using open coil springs. Molar discalization can be brought by using open coil nickel titanium springs compressed between the molars and the anterior segment. The anterior anchorage is reinforced by the use of an Nance palatal arch that rests against the anterior part of the head palate. Uprighting of molars. Premature loss of deciduous second molar or extraction of the second premolar can cause tipping of the first permanent molars mesially. Mesially tipped molar occupies more space than an upright molar. So by uprighting these tipped molars, some amount of space can be recovered. This can be done using molar uprighting springs or some form of space regainers. Derotation of the posterior teeth. Rotated posterior teeth occupy more space in the dental arch than normally placed posterior teeth. So derotation of these teeth create more space in the arch. This is achieved with fixed appliances incorporating springs or elastics. Proclination of anterior teeth. Proclination of a retroclined tooth results in an increase in the arch length. This is indicated in patients whose anterior teeth are retroclined or in those cases where proclining the incisors won't affect the soft tissue profile of the patient. Thank you.